Planning for end-of-life healthcare decisions is not just about old age. A medical crisis can happen at any age and can leave you or someone you care about too ill or unable to make his or her own healthcare decisions. Even if you're not sick now, making healthcare plans for the future is an important step towards making sure you get the medical care you want, even when doctors and family members are deciding for you. It can be overwhelming to be asked to make such serious decisions for someone who is very ill or dying. It's even tougher for people who don't have written or even spoken guidance about what types of levels of treatment their loved ones wanted for themselves. We are here today so that we can avoid those difficult situations. This afternoon we have 3 distinguished panelists to speak on this important topic. And introducing them briefly, starting to my left, Karen Griffith, who is from Compassion and Choices of Washington, which provides support to clients and families facing difficult decisions. Carla Jolley, who serves as a Palliative Care Advanced Nurse Practitioner at Whidbey General Hospital, and Grethe Cammermeyer, who is a retired Army nurse and owner of the Saratoga View Adult Home. I will give each of our distinguished panelists an opportunity to make some opening comments about why advanced healthcare planning is so important and the experiences they have had with these matters. I will then ask each of the panelists some directed questions. Afterwards, we'll open the floor to questions from our audience here and those following this forum on Twitter. When the time comes for questions from the audience, I will ask audience members who have a question to raise their hand, and we will come by with a microphone. So we're now ready for opening statements, and I'll start with Karen Griffith.
Thank you. Thank you, Marshall. It's a pleasure to be here and to be in such distinguished company as Grethe and Carla. I've worked in hospice for several years as a director of volunteer services. I'm on the board of the Hospice Foundation for Jefferson Healthcare. And as Marshall said, I'm a client support volunteer for Compassion and Choices. How many of you have heard of Compassion and Choices? Oh, quite a few. Okay, I'm impressed. Our mission is to promote excellent end-of-life care and expand the choices you have at the end-of-life care. We advocate for you having a very peaceful and humane death. Compassion and Choices of Washington is the organization that put together the coalition that passed I-1000 back in November of 2008. How many of you remember voting on that in 2008? Okay, interesting. What we found in our organization is that many people voted on it one way or the other and then kind of promptly forgot about it. And so I'm here to refresh your memory today about what it is you voted in or voted against. We educate people about all kinds of options toward the end of life and what their choices are and help them through those issues. We have client support volunteers all over the state that help people free. All our services are free. We provide information about advance directives, and as many of you know, we have a wonderful couple of advance directive workshops here in this building tomorrow, taught by Judy McKay, who's sitting in the back of the room. And the last but not least is we support and help people through the process called Death with Dignity. So when someone calls our office and said, I've decided I want to leave this earth earlier than when the fates may take me, we send a volunteer such as myself to their home to talk them through the process, kind of literally and figuratively hold their hand through the process, and then we are even there on the day they choose to end their life. The law passed with 60% of the voters in support of it. That meant 40% didn't support it. So we know we have some people who are in opposition to this law, but it is the law of the land, and I want to share with you throughout the next hour and a half here and there about what this law is about. How many of you kind of remember this story? Brittany Maynard in the newspaper and on the local news and the national news last November. She was a young woman, 29 years old, with a glioblastoma brain tumor. And she was living with her family in California, and they picked up and moved to Oregon, which also has a death with dignity law. She said, I want to choose when and how I die, and indeed she did on November 1st. And it was very, very sensitive and very sad, but I'm glad that she had that choice. There's lots of controversy around the law, and so I want to clarify some of that. First of all, I want to tell you that doctors have been helping patients who are near the end of life to die ever since there have been doctors. It's been done very discreetly, not a lot of fuss about it, but it's been happening for literally centuries. I want to be very clear about terminology. When we talk about death with dignity, we feel terminology is very, very important. This is not euthanasia, either voluntary or involuntary. Voluntary euthanasia is when a person asks a health professional to give them an injection of some sort, Dr. Kevorkian. Involuntary euthanasia is when we put down animals and capital punishment, where of course there is no consent. So in no way do we consider this euthanasia. Please don't refer to it as euthanasia. It is also not assisted suicide, which is a Class C felony in the state of Washington. And the reason it's not suicide is this. With suicide, a person often has some sort of a deep depression. They often take their life in a very violent way. They do it alone. They do it without warning their family or friends, and it leaves horrible psychological after effects. This is not that. This is now a quiet, peaceful death with family around. It is where a physician writes a prescription, where the patient himself or herself takes the medication. So we're going to ask you please not to refer to this as suicide, which it's not. It is not also a choice between life and death, because people who qualify for the law no longer have the luxury of choosing. They don't have an open-ended span ahead of them. They are facing a terminal illness. So if it isn't either any of those, we call it aid in dying or physician aid in dying. Only mentally competent people can do it, so that if you think about it being a slippery slope, well, first we're going to start taking the life of the mentally handicapped or the physically handicapped, etc., or people with Alzheimer's or grandma in the nursing home who's using up my life savings. Can't be done because it has to be done by a person who's mentally got all their marbles, has to be a legal resident of the state of Washington, age 18 or over, has to have the consent and the support of two different physicians. So it's not done easily or without a great deal of thought. Medical interventions are able to keep people alive long past the time where in the old days people would die of certain things like perhaps high blood pressure or hypothyroidism. Now with medical treatment and drugs, people are living long, long, long lives. And the downside to that is while we may want our lives to be good as long as we can, we certainly don't want our death to linger. And most people don't want to suffer endlessly once the possibility of living a good life is gone. So at a certain point, our physical bodies give out, and we're facing the inevitability of how we want to die. Hospice palliative care, very important component of death with dignity. And I'll be glad to give you lots of statistics later about how, who uses it, etc. But I will say this before I turn this over to Carla, and that is, it's not about escaping pain, interestingly enough. Only 15% of the people who use death with dignity say that pain is even an issue. Isn't that interesting? Only 15%. Pain can be well managed through great hospice care and palliative care, but it is lots of psychic and emotional pain, and there are other symptoms around the dying process that are not pretty to see or feel. And so this is about people who come to the end of their life and say, enough is enough. I will not let this take any more away from me now than it already has. So with that, I'd like to end, and we'll talk more about it with your questions, and give it to Carla.
Thank you, Karen. So I'm Carla Jolley. I'm a palliative care advanced practice nurse. And for those of you who are not familiar with palliative care is actually when we look at a new healthcare specialty in the last decade or two, really focusing on what we look at as far as quality of life issues. And so the focus of care and the focus, what I call another layer of support for patients and their families, because we know when someone has a serious illness, it is not just about the patient. It is about who supports them, their friends, their families, and sometimes it's about being in isolation if they don't have any support. So it becomes a bigger picture, a holistic approach. So when we look at palliative care, it focuses on pain and relief of symptoms and whatever the diagnosis. So a lot of times people associate just palliative care with a cancer diagnosis, but it also is for end-stage lung disease and heart disease and Alzheimer's, because in that spectrum of disease trajectories, we do all leave the world. Sometimes it is with advanced stage and frailty, but we do have a spectrum in that trajectory where we may be getting treatment or curative treatment for a long period of time. Then it may be just palliative treatment. We're trying to treat symptoms, and then it becomes advanced disease or providing support around end of life. And so when people often associate palliative care with just hospice care, and my feedback to that is all hospice care is palliative care in that we are looking at relieving pain and suffering and supporting the patient and family. But not all palliative care is hospice care, because you can access that approach to care, that layer of support, sooner in your journey with chronic illness. So it specifically focuses on people who have serious illness, because we know that that can add a lot of stress and concern around how best am I going to manage in the next few weeks, few months, and sometimes few years when we think about people who are living with end-stage dementia, which is a very, very difficult journey for families and their loved ones, much less for the patient themselves. So finding, what we know in medical care is that sometimes, those short 5 to 8 minute appointments don't always capture the ability to have what I call conversations. And so when we bring it back to advanced care planning, which is what we're here to learn a little bit about, is that palliative care really looks at that conversation around that. It really is not just filling out a form. It is really about having a conversation about what our values are, our beliefs are, what we want, what we don't want. The question that I always start with patients and families with is, what matters to you most? When you think about end-of-life care, what matters to you most? Is it remaining independent? Does it mean being surrounded by your families? Does it mean having a death at home? Does it mean feeling safe? What matters to you most? And I can't answer that question for you, but you can answer it for yourself. And even more important, if you are helping someone else in that decision-making process, what is their answer? Or have you ever asked that question? What does that mean to them? What matters to them most about where they want to be, what they might want to have happen? And the other thing that we often need to consider in these conversations is the decision points. Because along the line, when we talk about advanced care planning, it is important to get your information onto a form, but it is more important to know that it is a process. And every time you have another trip to the emergency room, or every time you have a stay in the hospital, if you're living with serious illness, there'll be another set of decisions to make. There'll be another person asking you, what would your mother have said if she could speak for herself? Well, that's easy for me to ask you, but it's not always easy to answer if you haven't had conversation about that. And conversation is important about, yes, do you want to be resuscitated or not, but it's more important about what is their value around that. Is it quality of life? Is it quantity of life? Was your dad always a full court press kind of guy and never give up? Or was it just like, I'm an old lady now at 88, and I lived a good life, and don't you dare take me to the emergency room, and don't you dare put a tube feeding down me, and don't you dare. Now that's fine if you have a parent that is quite strong in letting their wishes be known, but what about the daughter who asks the question and the mom says, that's very unpleasant, I don't want to talk about that. I mean, what do you do then? Because I'll come to you if I'm sitting if I'm sitting at the bedside trying to help families make decisions, I'll come to you and I'll say, what has your mom said? So maybe sometimes I can figure it out when they say, I don't want to be like Aunt Gertrude over there. No way, Jose, don't ever do that to me. Or they might say, you know, Uncle Joe had a great death. I want mine to be just like that. And so sometimes teasing that out is hearing stories. You know, what stories? Because stories is what informs us. If we had a good experience with a loved one, then that's a great story as far as what we might want for ourselves. If we had a bad experience, then we know for sure what we don't want for sure as well. And so when we look at that spectrum of continuum, certainly sometimes we're allowed to make a decision and we have some control over it. And sometimes, you know, health happens, health crises happen, and we don't always get a lot of time or ability to think about that. So we need to have talked to our durable power of health attorney. If there is nothing else that you do when you walk out of here, that is the one form to have, because that person's going to speak for you. We can write down our wishes and everything, but that set of decisions is always complicated. And so that person who's making those decisions for you really needs to understand what you would want or not have wanted. One of the things that I'd like to introduce and I put on your chairs is called the Conversation Starter Kit. And the reason that I am such a pro-advocate of this is that it's kind of that step before the advance directive. It says, you know, really, what are my values? What matters to me most? You know, how much do I want my loved ones in my business? You know, yes, no. Oh, yes, I do want them, but do they know what I want? Have I ever talked to them? Talks about how much you want to be part of that decision-making process as well. We, as a healthcare community, as a medical healthcare community, we started out, Dr. Goldberg, way back when, being very paternalistic and making all the decisions for patients several decades ago. Then we kind of swung the other way, and we said, okay, here's your information, make your decision. Well, I don't know about you, but a lot of us aren't sitting in this room with medical degrees. And so, you know, it's just like, well, you know, how am I supposed to know what I might or want or not want with that? So really what we're looking at hopefully as we're growing as a community that's responding to people's concerns about having their choices honored, is we want a shared decision-making model, meaning that I give my best, as I know, expertise about what's happening with you, what kind of decisions you might need to make, and then you tell me what matters to you most, what do you value, and what are you afraid of or afraid that might happen or what might not happen. So that becomes a very important conversation as well. So I encourage you to take a look at that. If you're a social media buff, it is on the website, very interactive, and has some lovely some videos. And she introduces this, particularly, and this is what I would like to point out. When we look at where people want to die, about 70% of them say, I'd like to die at home. When we look at the kind of not so great statistic, about 70% of us are still dying in hospitals, nursing homes, and facilities. So how do we make that different? Well, we make it different by being proactive. Just like the birthing movement, it didn't come from the medical community as far as fathers in the waiting room having birth plans, all those things. It came from consumers. And so your responsibility as consumers is to say, I want my choices honored, but I need to participate in that process too, which is putting a plan together, having a conversation with your loved ones about if they have to speak for you or what you might want to have happen as best we know. And if we don't know, at least they know what your values or beliefs are. So if I ask them at the bedside, what would your mother have wanted? What would she say to you right now if she could speak? Would this be acceptable to her or not? And you can say, you know, we had a conversation. Thank you.
Well, you've been hearing the process. I'm the pragmatist because you, in most cases, would not come to me. I have an adult family home. When I retired, I decided I needed to do something with 50 years of nursing. And my spouse, her mother, lived with us for 5 years, had progressive dementia, and needed a caretaker. Someone, and I thought it was going to be me because I'm so good. So I started doing her care and then realized that I was absolutely trapped. I could do nothing. I couldn't go see my kids or my grandkids or have any sort of a life, and realized that I was not alone in this, that there were other people who were going to be in the same situation. We've been talking about the process for us as individuals, but many of you may have family members who haven't had those discussions because they've been uncomfortable and you don't talk about it. Some of you may be familiar with this book called Can't We Talk About Something More Pleasant? It's really a fascinating, tragic story in a way. It's a cartoonist who tells the story of her elderly parents who don't want to talk about anything, don't want to leave home, and the process of finally having enough bad things happen to them that they end up in a care facility because they can't be taken care of at home. And then, of course, as children of aging parents, they always hook us. You know, there's no way that even though we're 60 years old, that we are 60 years old to our parents because they can say something or do something, and it just brings up that adolescent in us time and again. And you know, my father's nostrils would wiggle before he was going to say something that was going to push my button. But the point is that we have an adult family home. Decisions to a point have already been made by the time you realize that you can't deal with the family member, or you yourself don't want to live at home and take care of all of the issues, and you know that you're going to die. You have just gotten a diagnosis of cancer and have less than 6 months to live, and you want to be taken care of. And just live your life without any burden at all. And you may choose then to go to an adult family home rather than an assisted living facility or something like that. And then we contact Compassionate Choices, and they come and work with you as a member. In most cases, what happens is that someone is already losing mental capacity. Not only the physical capacity, but also mental capacity. And with that, you don't have the choice of how you choose to die. And if you think about it, none of us know how it's rare that we would know how we're going to go. And we would like, in most cases, for it to occur rather quickly. I've had a resident with me now for 6 years. She came with a broken neck, fractured femur, couldn't speak, had a concussion, and we cured her. She was up, walking around. Problem is that she had Alzheimer's. So she's been with us for 6 years, and we watch her just slowly lose capacity because that's the way the disease is. And there was a time when she said to me, Greta, you can help me. And I said, I don't know what you're talking about. But of course I did. And she just wanted it to end because she was feeling that she was losing control. But with Alzheimer's, we don't do that. And so we have to watch the process of somebody dying. The most difficult thing, I think, is for family members to make a decision about what do you do with mom, or dad. How do you get the support that they need if they are living at home alone or are living with you? You know, you have to try to sort all of these things out because it can get really, really expensive. To have 24-hour day care in your home at $20 an hour, that's more than $500 a day if you need 24-hour care. So it's trying to just manipulate the resources that are available and look at what options might be. Most of the calls I get are not about placement or having someone move into our home, but rather, you know, where do I go and where can I get some help and how can I find somebody to help out and to try to advise people on what some of the options are. By the time they come to a facility, at least an adult family home or something, these pulsed forms, the physician's order for end of life or for life-sustaining treatment, are usually filled out. And so that some decisions have been made by family members on behalf of their relative, which really is essential. And I think to have really open conversations about what is the cost, what is the risk of not having one of these forms. You end up on a ventilator and you die in the hospital. And that just really wipes out any resources that you might have. It wipes out the sort of the dignity that you might have also. It is an essential piece of paper as well as, or following after the advance directive that you have written that Carla talked about. Because otherwise you really have no say in it. And you have to have a little information about what's the benefit of CPR. What's the benefit of going on a ventilator? What's the benefit of having surgery when you are 95 years old, looking at, you know, whether it's something acute or something that would prolong your life? And I think that we sometimes can get hoodwinked into thinking that, you know, it's like putting a new motor in a 60-year-old car. You know, you've got a good motor, but the rest of it just isn't working. And no matter how much you try to repair the rusty holes, it ain't going to go back to where it was before. And I mean, the reality is that that's what our bodies are too. The minute you start cutting and pasting, it doesn't come together the same way. And you have to take care of it early enough so that you don't have to cut and paste, but then realize that, you know, it's the beginning of, you know, could be some real adverse effects in terms of your ability to care for yourself afterwards. I don't want you in my adult home. And I don't think you want to be there. Actually, you might. But the point is that you would like to have more decisions about how your life progresses as you get older. So I don't know that I have anything more profound and processed to say, but thank you.
Thank you. Well, I said we had a group of distinguished panelists. I'm more convinced than ever, aren't you? Yes. Let's give them another round of applause. For this section, I had prepared some questions for them, kind of as filler, but because what I want to know now is how many of you in the audience are prepared to ask a question? Please raise your hand. See, I knew this was going to happen. That's great. Because as it turns out, a lot of the questions I was going to ask, or some of them, were directly answered by this panel in their introductory remarks. But I do want to ask a couple, maybe. Surveys show that only a small percentage of patients have used an advance directive. In those with chronic illness, only 1 out of 3, surprisingly. And that only 18 to 30% of Americans have completed an advance directive. Lack of awareness is cited as the most common reason for not having an advance directive. Can you, and this is directed to all three, can you comment on the factors or barriers for not completing an advance directive? We'll just go round robin.
Oh, can I just say one thing? My favorite phrase around that, it's always too soon until it's too late.
Oh, I love it.
Yeah,
Good
I think
answer.
it's a real reluctance on the part of all of us to really face the nitty-gritty of I'm going to die. And it's real uncomfortable to actually stare at a piece of paper that is asking you to make black marks on it about what things you'd want done at the very moment or weeks before you're going to die. So I think it's kind of a natural thing for us to avoid the unpleasantness. So I don't think there's any mystery about why more people aren't doing it. There's a lot of things in life we would rather not do, go to the dentist, et cetera, and yet we do because we know it's in the long run better for us. So I think it's just simply a reluctance to acknowledge our mortality and to get real, as Grethe was saying, very pragmatic about the nuts and bolts of how I'm going to die. So this is our mission, certainly, in life. My sister in the back of the room, who does the advanced directive planning, and myself were the death sisters. And we just have a mission in life to get people to do this document. And when people give us the excuse of, well, I'm not really that old yet, I say, do you remember the names Terry Schiavo, Nancy Cruzan, and Karen Ann Quinlan? Do you know those names? All three of those women were in their 20s and 30s and ended up in vegetative states for like 10 years because they were, quote, too young to have thought about what they would do if that could occur. So you are never too young to be thinking about it.
I just want to add, I think the other thing is that people often think that it has to be done with a lawyer, and it does not. It certainly, as you know, you'll have a couple classes coming up, but it certainly can be done in a group setting or by yourself, or there's lots of resources out there to download and fill out forms. In Washington, if you download a form like it's the 5 wishes and it has a notary place, you need to have it notarized. But other than that, you don't have to, like I said, it doesn't take a lawyer to do it. So it's finding a form or finding a format that makes sense to you.
Thank you.
In most facilities, you can't even get in the door without one. And in the hospitals, that you fill one out when you register to get in. So if you don't think about it in advance, the time you don't want to have to deal with it is when you have to deal with it.
And may I just add one little thing about that? First of all, the state of Washington does not require living wills and advance directives to be notarized. It's kind of interesting. Many places, like 5 Wishes, et cetera, have a place for notarization, but it's not required. And secondly, if you have an advance directive in place, you have it written and you have copies to your various medical providers, and you enter the hospital and they give you another one to sign, don't do another one, because then that supersedes and makes invalid the one that you probably gave a lot of thought to. So what you want to do when you enter a medical facility is to take with you your advance directive that you've already created. So toward that end, my sister and I both have our copies literally by the front door behind a planter, so that we can take it with us. There's a copy in the glove box, et cetera. So just a couple of little twist to that.
So if you go to Whidbey General Hospital's website, there on the Advanced Directive Planning site, there is a form that you can actually download and have your send your advanced directives in ahead of time. And so even if you don't get your care at Whidbey General Hospital, a lot of times if you access emergency services, then you can they will open a chart just for you to have that on record.
Thank you. Well, since we talked about storage and copies of SAM, I want you to know that I have mine right here.
Good.
I never travel without it, including becoming a moderator using it.
Good.
So thank you. I'd like to ask one more question, and I promise I'll turn it over to the audience, because I'm sure this has come up before. What happens when a patient's advance directive runs counter to what the hospital or doctors want to do?
Well, I'll take one swipe at it, and then I'll invite the two of you. And that is that if it was my mother, let's say, and I took her to a facility that did not want to honor the advance directive, I would find another hospital. And if it was myself, I would say, could I go to another hospital? It's that important, because there are things that you want to be able to say on your advance directive about what care is done to you or not done unto you, that in a hospital that won't honor it could be done to you or not done unto you. And that's very serious. So that would be my first bit of advice.
So advanced directives, you never can put everything that ever will ever happen to you on it and the decisions that are going to be made. And I just like to give a quick example that, yes, it takes conversations with your family and your durable power of attorney, but it also takes conversations with the person who's providing you health care. My uncle, who had Parkinson's, did a pulse and was pretty clear, no tube feedings. But he was a little stinker and was out there doing bark dust and fell over and broke his neck. So he is down at Harborview. My aunt is having a meltdown because he said no tube feedings. But he is not at end of life. It is not about this is a life-prolonging measure. This is a temporary intervention. Right. So he had the tube feeding placed. He had it removed after he didn't need it, and he had healed. And at his end-of-life event, which for end-stage Parkinson's, one of the decision points usually is about tube feedings, his wishes were honored. So again, advanced directives are guideposts and are tools for healthcare providers to have a starting point, but sometimes we have to go back and have conversations. You're right that it's important to honor them, and if you're not feeling honored, there are definitely chains of command. There's ethics committees in ensuring appropriate care. There's ways to be able to be heard if you feel like that is part of the conversation as well. In all different kinds of healthcare settings, there are places to go with that as well.
Well, I think this is one of the concerns that we who work in hospitals have had regarding affiliations. That whether or not your end-of-life decisions and advance directives would be followed if you were in a church-affiliated facility. And as was mentioned, don't go there because you will end up being treated according to the religious doctrine of the facility rather than your own wishes. Whidbey General Hospital is not affiliated. It stands alone. Taking on the world.
On that note,
oh, that may be more real than...
I thank you all for that. I'd like to now turn to audience questions, but I do want to remind you of a few things. Please stand when you ask your question and let us know which panelist your question is directed to. We would also appreciate it if you would identify which community you're from and if you represent a specific organization. If you have a comment to share first, that's fine. However, please limit it to a minute so that we can get the maximum audience participation possible. I do reserve the right as moderator to move you along if you're taking too long to get to your question. That's why I signed up to do this in the first place. For those who join us by Twitter, please tweet your questions and comments as you have them, and we will ask them at the appropriate time. So now we turn to audience questions. We have two roving microphones. We have a Debbie, I believe,
Kate.
Kate, and I'm sorry, and Becky. Becky, okay, go ahead.
Yes.
All right, so I guess probably, Carla, you might be the better answerer of this. As far as how many copies of a single directive should a person have around, and where should they be stored?
So definitely not in the bank
deposit
safe
box.
deposit box, yes. So, like I said, get a copy to your providers. If you have specialists, get a copy to your specialists. So, I mean, part of it helps them to understand what your values are. To whoever you said was your durable power of health attorney, to whoever might get called as a person who's on your emergency contact list, in your glove compartment, like Karen said, and then also one in your purse. You can never have enough. Never have enough copies. But the piece is, if you change them, you want to make sure you've kept track of where you've put copies out, because that's important if you've updated them as well.
Let's see, next person.
I heard recently that if you have a directive and you say on there, do not resuscitate, and then if you are unconscious and someone else calls 911 and paramedics come, that they are required to resuscitate you. Can anyone tell me if this is true?
It is true, unless you have taken that advance directive and you've turned it into a pulse. So, because the EMS has a responsibility to respond to an emergency if someone's called 911. And if someone does call 911, the only way they can kind of break that is to, certainly if someone's there with you that knows your wishes, they can certainly talk to the physician that's overseeing that code. But really what you want is a pulse, and that is a physician orders and that has signed by your provider that says to the EMS, do not resuscitate me. That's the first question it says, and that gives them legal right not to start CPR. Okay.
Good question. Very good question. Next person, hand over there. Thank you.
I have just a couple of questions. One is if patients or clients want to put specific provisions in their advanced medical directive or their living will, like they want to put a specific time limit or minimum time limit or any other specific instructions, are those always honored by the medical providers? Or how are those handled? And then the other question is, if there is an advanced medical directive or a living will, and then there's a medical power of attorney, and the patient is not able to speak for themselves, if they conflict, then what in reality, what happens at that point?
Go ahead. You alluded to that earlier.
So again, advanced directives in and of themselves are, guideposts that give us the medical community as best we know. And if you're telling me you want a trial of tube feedings, what does that mean? It might mean something different in different scenarios, but it gives me a sense that you would like to kind of say, if there's something reversible, maybe I'd like it reversed, but at some point, I want you to give up. Or we may be forced to give up, the other piece of that. The durable power of health attorney, that person, that's why I say that person is so key in the equation, because they can, again, you've given them the responsibility to speak for you and to be your voice. And if they've been assigned that, then the assumption is they're going to speak what your wishes are. And like I said, we can't always know as far as what may or may not happen to people, and there are nuances in medical decisions that need to be made. And so in what we do default to is the medical power of health attorney. And if it is in conflict, then that's a problem. And that's why I was saying that advance directives are important because they communicate to the medical community, they communicate to your durable power of health attorney, but more important is that you're having conversation and you get a sense of whether your loved one or who you have assigned is going to speak your voice, and because they will be speaking for you. Yeah.
Okay, thank you.
My question is directed to, I think, both Grethe and Karen. You mentioned, Grethe, that you have a client who has Alzheimer's and has been there for 6 years. And I guess my question to you is, if in her directive she specifically said she did not want to be around when her mind wasn't working right, what happens then? Can you get the assisted?
Unfortunately, the law is written so that the person applying to use the the death with dignity has to be mentally sound. So by the time someone with Alzheimer's or dementia is terminally ill, which is another requirement of using the law, they no longer are able to make that kind of a determination, even though they said it a long time ago. That's unfortunate. Now, Compassion and Choices of Washington does have an advance directive for people with Alzheimer's, but it's meant to be filled out by people who are in the early stages or fear that they are getting Alzheimer's, and it takes care of all kinds of things about your care when you are no longer able to make those kinds of decisions. But unfortunately, because of the protections and the safeguards that were built into the law to preclude abuse of the law, it was necessary to say you must be able to make a sound decision. Therefore, what are the choices left for someone with Alzheimer's? And sadly, there are not many. And Grethe can speak more to those after I say the following. And that is, we know of people in the early to mid stages of Alzheimer's, and that's difficult to even determine because it's such a long slide, that have chosen to do what we call voluntarily stopping eating and drinking, so that they had still enough decision-making capacity, not allowed to use death with dignity, but have said, I'm through taking in any liquid or food. And that's a choice that is still up to them. And then down the road would be on the part of the caregiver who, shall we say, chooses not to treat something. For example, a UTI, a urinary tract infection, or pneumonia toward the end of life with an Alzheimer's person is, and not treat it, is often a quiet, nice way out if the symptoms are treated. Grethe, you can probably add to that.
Well, it's the conversation that you have with the family. The family determines, the powers of attorney determines when they no longer want a family member treated. And sometimes we have, the problem is that we get so good in prevention that they don't have the treatable illnesses or complications to allow them to pass. And so that becomes a problem on the one hand, and the good thing on the other. But, we don't die of Alzheimer's. We die of a complication, a pneumonia, urinary tract infection. You have somebody that takes a fall and then they break their a limb and they end up in the hospital, and then it just deteriorates from there. So it is one of those long, progressive problems where you can't do anything specific, but you can just withhold treatment for something that is acute.
Thank you very much. We're getting more questions now. Forgive me if I don't pick you in the order in which you rose your hand. This gentleman, I remember. Go ahead, sir.
Just a couple of short questions. Carla, and I'm confused about this. Can you get does the hospital take in advance healthcare power of attorney?
Yes, yes. You can, any of your forms can be put into a medical record, whether you've received care there or not. You just go down to medical records and they'll open up a chart.
Okay, and also that green form, I'm not sure I understand what that is and where you can get that.
So this is a form that for people who have a serious illness or chronic illness or have a reason to think that they're getting towards those last few years of life and are very strongly want to make sure that absolutely nothing happens, that they don't want to have happen, and that has to be signed by your provider. So they have them in all the providers' offices, and it's a conversation to have with them and fill out with them. I'll be happy to give you one, but to make it.
Apparently, I don't need it.
No, you don't, not yet.
But to have it valid, it does have to be signed by a provider and also by the patient or their durable power of health attorney.
And finally, can the person that has the durable power of attorney for your health care, can they override, or can you make it that they can override whatever is written? For example, if you want to say you want to have a DNR, if you're, I mean, if something happened to me and I had a heart
Right.
attack, of course I want to be resuscitated if my heart stops, because I have some expected life ahead of
Right.
me, but
Right.
there's a difference between a DNR when you don't have any expectation of life and when you do.
Right.
And so I'm concerned how that works.
Again, that durable power of health attorney, making sure they just understand what your wishes would be or not be, so that when they come to that point to make make those decisions, they know what you would want under what circumstances and what you would not want on other circumstances. And that's why I'm saying that advanced care planning is a process. As we age every year, I had one lady who, bless their little family, that was the conversation of the Thanksgiving dinner. Everybody had to show up with their advance directives and update them depending on what happened the year before, or they didn't get their dinner. So I think that actually is a really great idea, that, because we do, the health changes, our attitudes change, what's happening to mom or dad changes. So it's important to keep the process going, not just do it and put it away and don't think about it again.
And if you do have a pulse,
Yeah.
make sure that it's available.
Yeah.
On your fridge.
Usually on the refrigerator, or at least in the drawer of the nightstand or something like that. When my spouse's mother died, she never moves fast for anything, but on my spouse. But on this particular time, she called to let 911 know that she had died. They got there so quickly that, she was barely cold. And we couldn't find the pulse. And so, in this 95-year-old emaciated dead woman, they were going to start CPR because they had to, because that's what their job is. They are the first responders. And I, with my military background, I was said to either drop on her body so they couldn't touch her, or go and get my gun to protect her body. But we eventually found this, and the sheriff came and so protected the EMS people. But you want to make it so that this is available if it's needed, because unless you're in a facility, for example, in our facility, if someone dies and they have a pulse, I can pronounce them because I'm a registered nurse. But if it's anyplace else, you have to have somebody that is, I won't say qualified, but is allowed to pronounce someone. And so the EMS people are the first ones that show up. And so just have it, make it available, have them see it, and then nature takes over in a much more calm way.
Thank you. I want to turn to my right. This is the neglected part of the room. So, does anyone over here
annex.
want to ask a question? See, they're engaged. They're really being, okay. I can't tell who was what, when they were. I remember this hand. I'm sorry, I apologize if I overlooked you.
Well, my question is a follow-up on the last comments. Marshall has his durable power of attorney with him. Yours is behind the potted plant. People I know who have pulse have them on the refrigerator. How, in situations where you're not at home, do you make your wishes known?
Well, it's either in my glove compartment in my car or it's in my suitcase. So I've got a pretty good chance that
What
if I'm
happens
not
when you
at
go for a
home-
hike?
Yeah, well, then you're going to be at the mercy of
Well, you
who's
end
your
up-
companion,
Okay, so there's
who
nothing
could
like a
speak for
sticker
you.
you can put on your
No,
driver's license.
No, so
not
you end up
really.
in the hospital.
Yeah.
Assuming that you make it there. And your next of kin or whomever is contacted, and they then will have to make a decision depending on how aggressive the hospital has gotten prior to someone in the family being notified, which is the advantage of having something with you, or at least in your records or something like that, so that you're not on a ventilator before somebody comes and says they didn't want that. So it's, I'd like to tattoo it on my chest, DNR. These are the things that one has to think about in making decisions about what you take with you and the paperwork that you have already done that's at home.
Thank you very much. I'm not the technical person, but I presume a digitalized form would work if you loaded it up into your computer or your smartphone and then had to produce it in the emergency room or somewhere. Would that work? It doesn't have to be the original document, or does it?
Well, I mean, we're entering a new stage for sure. Yeah. If what they need to know are your wishes, and if that form tells us what your wishes are, then that informs then as far as that decision making. Is that a guarantee? No, but it will help. Yeah.
Okay.
Yeah.
Thank you. Let's do someone in the back this time. That lady over there in the back. And I'll come in towards the middle. This is where I'm going to move.
My name's Sandy Malky, and I'm with Regency on Whidbey in Oak Harbor. And this is really directed to caregivers in the room. If you are a caregiver and your spouse or sibling or whoever you're caring for is at home, and you have run to 7-Eleven to pick up a jug of milk, God forbid you're in an accident, no one knows that the person you're caring for is now alone. My suggestion is to wear like a MediAlert bracelet that says, I am the caregiver for, which would prevent some disastrous situations. Just a suggestion.
Excellent.
Great.
Thank you very much for that.
Yep, I like that suggestion.
Okay, I promise we're moving this lady
Yeah,
over
yeah,
here.
she's had her hand up
Please.
for a long time.
This is more a comment than a question. I don't fear death. I fear living with dementia or Alzheimer's.
Yeah.
I'd like to see the Death with Dignity or the Compassion and Choices of Washington work on that. In what way, I have no clue. But I would like not to fear living with that disease forever.
I know. I hear you.
Okay.
I'm still confused. I've got a health care directive, which I filled out and left with a friend and my daughter. And I never heard of that green form before, and somebody's going to have to spell it because I didn't hear. I can't tell what it is if I'm going to ask for my doctor. And I've got 2 of those little pill bottles that I picked up from the hospital with information filled out in them that's a little bit different. Now, I'm willing to, condense one of these into the pill bottles and carry them, but which one should it be? I still don't get the difference between the green thing and the health care directive. So could you speak to that?
Yeah, so the POLST, P-O-L-S-T,
It's an acronym.
it's an acronym, stands for Physician Orders for Life-Sustaining Treatment. It is, the intention of it is for people who have serious illness or chronic illness or advanced age or have some reason to think that they have a shortened life expectancy in the next few years. And your physician or your provider may be able to say, this is appropriate or not appropriate for you, because they're the ones that have to sign off on that.
Thank you. Let's see. Let's go to this lady right here.
I'm from Oak Harbor, and if anyone has difficulty hearing, this library loop is wonderful. And also, every time Grethe said pulsed, I thought she was saying pulse, if they have a pulse.
Yes.
Well, sort of
That's
goes along
important
with
too.
it.
Indeed.
Pretty vital.
So when I came to Washington about 10 years ago, I did go to an attorney, and I have the advance directive and a power of attorney, but does that, I have a feeling the post form is more comprehensive than what I filled out at that time. Does one need to return to that and make sure that that's up to date? I am going to do the post form, absolutely. But one thing I've learned a lot today. Very grateful to hear about keeping it in the car, because that's where you very easily could have an accident, or so that's great. I've learned a lot from attending the classes that Sandy gives or is part of for caregivers. So my question would be, do I need? I know about the attorney and that it has to be given to the ambulance to the medics when they arrive. And but I don't have enough copies, and so I've learned and will behave myself in future. Thank you very much.
The Pulse form does get periodically updated, and it was updated in, I believe, March or April of last year. So if you've got one, first of all, I don't know why you would have had one 10 years ago. You're way too spry and sprightly to have had one. But it does get updated. There's a committee in the state that works on it, and it was recently updated. What does that say, Grethe? Because ours, I think,
Well,
March
I think,
of 2014.
Well, this one's the 2011. There was
No,
just a little
2014, aren't
yeah.
they, Judy? The latest one? Yeah, so the latest ones are fresh off the press. And again, I want to reiterate what Grethe and Carla have both said about that pulse. Is, as I kind of just look at you, most of you probably wouldn't need one yet, because it really is for, as Carla said 2 or 3 times, for the frail, for the people who are really on that proverbial banana peel, shall we say, and are pretty homebound, and you don't need multiple copies of it. You can have, but you just need the one kind of on your refrigerator, because that's where EMT is trained to look for it. So you wouldn't need one from 10 years ago updated, because you probably didn't have one that was up to date. But there is one that's fairly fresh off the press within the last 6 months to, and your doctors have them. Your doctors have them. Ask your doctor, do I need a pulse or not? And your doctor will say, no, I don't think it's time yet. Or the doctor may say, yeah, it's time. That's kind of scary. It's time.
Thank you. I think what we'll do, I'd like to take one more question from the audience, but let you know that after we conclude our program formally, we will have about a half hour informally to mingle with our panelists and amongst each other to talk about some of these issues further. So I'll take one more question. I saw a hand go up. You, sir.
I'm going to retract my question.
Would you speak in the microphone, please?
Yeah. I'm going to retract my question because I would rather direct this question to either of you panelists or specialists. Because as an atheist, I have very specific concerns about when and where the post will be accepted or rejected. Specifically, I want to know about Island Hospital. So I'm not going to put you to the test here before
Does anyone want to?
I don't know if Highland is affiliated or not.
No, Island Hospital, I can say.
Did you say Highland?
Island.
Island.
Island Hospital is not
Not
affiliated.
not affiliated.
You're safe.
Okay? Island Hospital, the last I heard, was the only hospital in the state of Washington that actually provided for death with dignity on its staff, through its staff members. The only one. But yes, there's two. I'm sorry, I'm correct. I understand that, yes. He asked about, yeah. He was speaking, we're speaking to Island Hospital in Anacortes, not Whidbey General. I think can we go on from that? We have these looks, I'm looking at these looks here. Okay, what I'd like to do now, I thank you for your questions. We're at the close of our program this afternoon, and before we conclude, I'd like to ask each of our panelists to answer this final question. It's a trick question. If the audience members were to take home just one message today, what should it be? In any order that you want to respond to. Just one message.
I'll start then. The one message I would like you to take home is that you have a wonderful organization in this state, Compassion and Choices of Washington, who stands ready to help you if and when you get to that point when you want to use the death with dignity. Short of that, Compassion and Choices stands ready to help you with preparation of advanced directives. We have developed, with the help of a senior elder law attorney at the University of Washington, an advanced directive that combines both a living will and a durable power of attorney into one document. It has been vetted and tested and molded and loved, and it is a wonderful document. And it even has some aspects about it that really delve into sort of the possibilities of Alzheimer's affecting some of your care, et cetera. So I would urge you to attend the workshops tomorrow or on March 23rd. If you're unable to do either of those, I would urge you to get onto our website, compassionwa.org, and download the advanced directive that we have there, and the Alzheimer's advanced directive is also on our website. So that's what I want to leave with you, is an awareness of this organization filled with compassionate people who stand in awe of the death process, who consider it a privilege to hold the hands of our clients when they actually make that step, and to know that you can indeed have a good death. That's what I want you to know.
Thank you. Carla?
So, around advanced care planning, if you didn't hear me before, the most important thing is that person who's going to speak for you when you can't, and that they understand your voice and what that might be and what matters to you most around that. I would use the tool, the Conversation Starter Kit, for those who have people who are difficult to engage in those conversations. They even have icebreakers in there. And also to look at this spectrum of choices that are available for you at end of life. When you're living with a serious illness, certainly we look at hospice when there is no longer a cure, but we're looking at focusing on comfort. It is about living until you die and allowing that natural death and supporting that through that interdisciplinary team. If you're in the process of still getting palliative treatment further up the line, looking at what else is out there available for you as a supportive layer. It's an amazing community. For such a small community, we have some great resources, and look at what those might be to support you and your family in this journey. Thanks.
Thank you.
There is another really quite exceptional book called Being Mortal that has just recently come out. It's a physician who sort of has an epiphany in terms of, and they do occasionally, don't they? Yes. But that it sort of takes you through how we ended up having nursing homes and assisted living facilities and that sort of thing, and then vignettes on sort of the process of dying, depending on what the illness was of the particular patients that he's talking about, and then his own journey to understand hospice, to understand the importance of having those conversations early with significant others, whether they be family members, direct family members, or parents or children, so that everyone hears the same message, and that's done while you can still make the decisions, rather than leave those decisions for somebody after you are in the hospital, or when they have to make tough decisions about whether or not to take you off a ventilator. You don't want to leave those decisions for someone who doesn't know what your journey is, and I think it really reflects well what happens if you don't do the work when you can. My kids have known for a long time, do not resuscitate. But that's my choice and my values. I'm too bullheaded for anything else. But so were these parents of this particular writer. And so there's some humor in both of them, but there's also the seriousness to give you some ideas if it's such an uncomfortable subject, or you haven't been around people as they take the journey to that next phase.
Who's the author?
The last name is Gawande. That's why I didn't say it.
It's Atul, yeah, I believe it's Gawande.
Gawande.
Atul Gawande. Well, thank you very much, Grethe. We've come to the end of our allotted time. If you've not already done so, please complete your evaluation of our program and discussion. Sno-Isle Libraries would appreciate any suggestions on how to improve issues that matter, forums, or ideas you may have for future topics. At this point, I'd like to recognize our panel. Please help me with a round of applause. I also would like to thank you, our attentive audience, for your thoughtful questions and comments. Please give yourselves a round of applause. And last but not least, I would like to thank Sno-Isle Libraries and the Sno-Isle Libraries Foundation for making this forum possible. More applause, please. If this afternoon's discussion has made you even more curious about this topic, you can explore the many information resources available through your community library or on the Sno-Isle Library's website. You may also wish to attend the next classes on writing an advance directive scheduled for March 23rd. The classes tomorrow, by the way, are full. The classes on March 23rd will be taught by Karen Griffith and Judy McKay of Compassion and Choices, and will be held here at the library at 9 a.m. and 1:30 p.m. Spaces are limited to 35 per class, and pre-registration is required. After we adjourn, please feel free to stay for the next half hour or so and chat with each other and our panelists. Thank you again for coming.